only increasing our knowledge globally, but are also inspiring us to dream bigger in life. Now, as our institute holds the mission to produce high quality pharmacy professional and curriculum innovation by adapting to the needs of global transformation. So to light our mission, here comes today the second webinar in the series, digging the topic, evidence synthesis and patient care, delivered by our respected speaker, Dr. Prashant Sakharkar sir from Roosevelt University College of Pharmacy, USA. We welcome you, sir. And before sir elaborate the topic, I would like to introduce the topic in short. So evidence-based clinical practice is a thoughtful use of the best research evidence, clinical expertise, and patient values to create a plan of action regarding patient care. Evidence synthesis, or also called systematic review, is a way of combining information from multiple studies that have investigated same thing to come to certain conclusion and utilize it to optimize patient care by providing best possible treatment. So basically it is a tool used by the researcher, healthcare providers every day that play an important role in making important decisions of matter related to healthcare. It is a way of making sure that the views and healthcare decisions are based on the finding and lots of studies rather than just one. This can include of how effective a certain treatment or drug is, or what people view a experience of that treatment may be. So evidence synthesis can ultimately save patients' life. So our today's speaker will discuss in detail process of evidence synthesis and its application in patient care. So over to you, sir.
Thank you, Madam. Now I would like to invite Professor AJMIRE sir. Sorry. Now I would like to invite Dr. R.L. BAKAL sir, Principal of Dr. Rajendra Institute of Pharmacy, for giving the welcome speech and inaugural of today's session. Over to you, sir. Yes, sir. Your mic is unmute and your video is visible.
So, am I audible?
Yes, sir. You are audible.
Again, very warm welcome on second day of our international webinar series. Today's webinar we have Professor PRASHANT Sakharkar as a guest speaker. I have immense pleasure to welcome you all. So I welcome our today's guest speaker, Dr. PRASHANT Sakharkar. Hi, PRASHANT.
Hi.
As a convener of this program and on behalf of my management. So, good evening, sir.
Good evening.
Good morning to all participants of this webinar. Again, I am very much thankful to my all supporters, sponsors, and the president of our institute, GODE sir. Again, like yesterday's seminar, this will be very informative, productive, and the things new for us. And again, I especially welcome all participants of this event. Thank you. Over to ANDE. ANDE sir, continue.
And Sagar sir, your Your voice is unmute. Sagar sir.
Sorry
Yeah,
for
yeah. It's
interruption.
okay now.
Yeah, I would like to invite Professor AJMIRE sir to give the introduction of our today's eminent speaker, Dr. Prashant Sakharkar sir. Over to you, sir.
Good morning to everyone and good evening to Dr. Prashant Sakharkar sir. Dear all, today we got the eminent personality, Dr. Prashant Sakharkar sir. Sir is currently an associate professor in the Department of Clinical and Administrative Sciences at the Roosevelt University College of Pharmacy and in Chicago. In the area in the state of Illinois, Dr. Sakharkar sir earned his MPharm degree from Nagpur University and PHARM.D and Master of Public Health degree from the University of Florida in the United States. Dr. Sakharkar sir also completed a 2-year postdoctoral fellowship in the health outcomes uh, research at the Western University of Health Science College of Pharmacy in California. Dr. Sakharkar sir began his professional career as a lecturer and spent near about 6 years at the Institute of Pharmaceutical Education and Research in Wardha. Then Dr. Sakharkar sir worked for 8 years as a senior pharmacy manager of inpatient pharmacy services, managing near about 460 bed acute care hospital in abroad. After completing 2 years of postdoctoral fellowship, Dr. Sakharkar sir joined Roosevelt University College of Pharmacy and as an assistant professor, and where he later promoted and tendered to his current position of associate professor. Now, Dr. Sakharkar sir research focuses on economic analysis of drug therapy and pharmaceutical care and assessing health outcomes in renal transplant and patients with chronic disease. He is also involved in public evaluation of public health program. Dr. Sakharkar sir has number of publications to his credit in peer-reviewed international journals, presented his research at several national and international conferences. Dr. Sakharkar sir was recognized and as an outstanding reviewer by Research in Social Administrative Sciences Journal and JAFA, a journal of American Pharmacists Association, and he currently serves serves on its editorial advisory board. Dr. Sakharkar sir is also an editor in charge of Journal of Basic and Clinical Pharmacy and on the editorial board of Journal of Research in Pharmacy Practice and Journal of Diagnostic Research. Just to his name, a few. Dr. Sakharkar sir served on the American Society of Health System Pharmacists Pharmacy Practice Research Review Committee for past several years and reviewed research for numerous journals and Pharmacy Worldwide Research Advancement Award Committee. Uh, uh, Dr. Sakharkar sir, he has also served on the American Association of College of Pharmacy Worldwide Research Achievement Award Committee, Rufus a Layman Award Committee, and New Investigator Research Award Review Committee. Dr. Sakharkar sir is an active member of American Pharmacists Association, International Society for Pharmacoeconomics, and Outcome Research Academy of Managed Care and Specialty Pharmacy, Indian Pharmaceutical Association, Association of Pharmacy Teachers of India, and several other professional organizations. He is a Senate member of Roosevelt University and member of University Faculty Dispute Resolution Committee. At the College of Pharmacy, Dr. Sakharkar sir is currently a member of Assessment, Curriculum and Scholarship Award Committee. Dr. Sakharkar sir loves for traveling and visited over 16 countries in Europe and North America. He loves music, movies, and cricket, and is actively involved in Indian community and supports social causes here and abroad. So it is my great pleasure that we have with us Dr. Sakharkar sir, an eminent personality. I hope all the participants will enjoy today's webinar. Thank you, Sagar sir, for giving me this opportunity. Over to you, sir. Sagar sir.
Thank you, sir, for giving such a wonderful introduction about our today's eminent speaker. Now, today in our session, we welcome to our guest of honor, Dr. Anil Chandewar, sir, Principal, P. Wadhwani College of Pharmacy, Yatmar, having more than 25 experience in a educational field as an academician, as a research person, and as a administrative in the field of the pharmacy. So I welcome to Dr. Anil Chandewar, sir. He will give today's view regarding with the session and will also guide us.
Okay.
Yes, sir. You are.
Yeah, I am audible now.
Yes, sir.
Okay. So, hi, good morning, everybody.
Yeah, good morning, sir.
Good morning, Prashant.
Good morning.
Good morning, very good morning. Good morning, Bakal, sir. Hello. Actually, good morning, good morning. It's a very nice initiative taken by Dr. R.G. GODE College of Pharmacy, Amravati, by arranging such a beautiful international webinar. And today's speaker is an eminent speaker. He's a good friend of mine. We worked together in Wardha, and we enjoyed a lot of our teaching profession. We got number of things from that Wardha College of Pharmacy itself, and the personalities were developed in the teaching profession. What to talk about Dr. Prashant Sakharkar? He is a versatile personality. He is a good teacher. He is a good administrator. He is a good performer also. And I hope that this today's session will be very beautiful and very informative. He has plenty of knowledge as he is serving in USA since a long time. So I am confident that his session will be very informative to the all participants. And I give the best of luck for this international webinar. And thank you very much.
Thank you, sir.
Thank you, sir, for your words. Now, without wasting our time, we are on the time for starting our today's session and to listen the Dr. Prashant Sakharkar, sir. So I would like to invite Dr. Prashant Sakharkar, sir. You can start your presentation and later on for the discussion. Over to you, sir.
Okay, how do I share my screen?
Yes, sir. You are visible right now.
Okay. Okay, you disable my screen sharing, so probably you may have to enable it. The screen sharing option.
Yes, sir. I will going to make you a co-host just now.
Yeah.
Yes, sir. All the options are open for you also.
Okay, great.
Screen is visible right now.
Okay. So thank you and good morning to everyone. It's my pleasure to be speaking with you this morning. You know, every day we are bombarded with news stories, news reports, and TV commercials touting about the benefits of new drug, new intervention, new treatment, new dietary supplements. But how do you know that the claims that are made in these TV commercials are in fact true? So as a healthcare professional, it is our job and responsibility to understand that all treatments are not better. They can also harm people. The expert opinions that are delivered by clinicians are not always right. The things that we do in our day-to-day life or in practice may not be always based upon some evidence. Newer drug or newer treatment doesn't necessarily mean that they are the better drugs or better treatment. And lastly, association is not same as the causation. Just because you have seen something as a phenomenon or trend does not mean that there is a causation involved in it. So how do we distinguish between right and wrong? How do we process and assess the research evidence? How can we make an informed decision as a healthcare professional to improve patient care? And lastly, how can we respect our patient and value their preferences and choices? So this is the topic of my today's presentation, titled Evidence-Based Clinical Practice, Evidence Synthesis, and Patient Care. So at the end of this webinar, there will be a live QA session, and there will be some polls and interactive quizzes throughout the presentation. So the folks who may have joined us late, for their information, my name is PRASHANT SAKHARKAR. I am an associate professor in the Department of Clinical and Administrative Sciences at the Roosevelt University College of Pharmacy. The building you see here, the blue high-rise building, is our vertical campus. It has 32 floors. It is the second tallest building, higher education building in the United States, and it is sixth in the world. Our campus is situated in downtown Chicago, just across a beautiful lake called Lake Michigan. Our university also owns an auditorium theater, which is seen here in orange color, which is the oldest theater in Chicago. It was built in 1889, and it was recently recognized as a National Historic Landmark. Our university also offers courses in pharmacy, nursing, allied health sciences, business, and performing arts. So this is a little bit about me and my workplace, but I'm more interested in learning about you. Since we are using this virtual platform, I cannot see everyone on my small screen. So what I'm going to do here is going to use an online poll and going to ask you two simple questions about yourself. So what you see on this slide is a QR code which you can scan, and it will take you to the website where you can answer this poll, or you can go to this website www.menti.com and add this 6-digit passcode to access that poll. So are you guys ready? So I'm guessing that this is the morning time. You might be having your morning cup of tea or what we call chai. So there are some fun facts about a morning tea or chai.
Sir, I have copied that scene. I will post it in the group. You can continue with your presentation.
Yeah. So just tell me about yourself. Okay, so we have faculty members. We also have students, bachelor, masters, and PharmD students. That's great. Okay, so majority of you have heard about the evidence-based medicine and know a little bit about. Some people want to know more about. So let's do that. So the objectives of my today's presentation are listed on this slide, but I have broken down my presentation into 3 parts. So in the first part, I'm going to talk about the concept, application, and the process of evidence-based medicine. In the second part, I'm going to discuss a little bit more about the nuts and bolts of evidence-based medicine. And in the last part, I'm going to talk about how to practice evidence-based medicine based upon some patient scenario. So before I move to the next slide, I want you to imagine something that you would love if that happened to you. Imagine something like meeting your favorite cricket player or meeting your favorite Bollywood star. Since you are a pharmacist or you're going to be a pharmacist, I want you to imagine something like meeting a Bollywood star, or the Bollywood star is walking down to your pharmacy or your workplace and asking for your help with the medication. I'll give you a couple of minutes. So the picture you see on this slide, these are the 2 Bollywood stars that are popped out of my imagination, but you can replace those pictures with your favorite people. Now, these 2 Bollywood stars, they are in their late 50s and they are concerned about their health. Recently, they saw a TV commercial about the aspirin, which was claiming that taking a low dose aspirin every day protects your heart and prevents future cardiovascular events. These stars, they are in their late 50s and they have a question about whether they can use aspirin or not to prevent any future cardiovascular events. So as a pharmacist, before you advise them, you need to find out a little bit more about them, about their medical history. So your first patient, who is also called as Saifu or Chote Nawab by nickname, he is a 50-year-old male, 5 feet 8 inches tall, weighs approximately 78 kilos, with brown eyes. He is married and a pet lover. He is a professional actor and a part-time guitarist. He has a family history of heart disease. He was a heavy smoker in the past. However, he quit recently. He drinks alcohol occasionally. His past medical history includes myocardial infarction and a minor heart attack at the age of 36. Whereas your second patient is 46-year-old male, 5 feet 6 inches tall, weighs 85 kgs, has hazel green eyes, divorced, and also a pet lover. He works in Bollywood and is a certified professional diver. He used to smoke in the past, but stopped recently. He drinks socially, and his past medical history includes stammering in the childhood and scoliosis. He has also suffered depression in the past and had a surgery for chronic subdural hematoma, which is nothing but a blood clot in the brain, about 7 years ago. So these two patients, they are concerned whether they can start taking aspirin because they are in their late 50s and they want your opinion. So my lecture is going to be centered around these two patients. So let's start with the first question. What is evidence-based medicine? Okay. So in late 1970s, a group of clinical epidemiologists at the McMaster University in Canada, led by Dr. David Sackett, published a series of articles about how to read and evaluate medical literature. Several years later, in about 1980s, Dr. Sackett suggested applying this evidence obtained from medical literature to patient care. 10 years later, in around 1990s, Dr. Gordon Guyatt and Dr. David Sackett together worked extensively to critically appraise the medical literature and bring that to the patient bedside. And they referred this practice as evidence-based medicine. Since then, there are a lot of terms that are derived from the term evidence-based medicine, but more or less they are same. They are just related to different types of practice. For example, nursing, dentistry, pharmacy, public health. So we normally refer to them as evidence-based clinical practice or evidence-based nursing practice or evidence-based public health practice. But the principle of those practice are same. So in this lecture, I'm going to use this term interchangeably. So if you look in the textbook and in published literature, the EBM is defined as the consensus and explicit and judicious use of current best evidence in making decision about the care of the individual patient. But in a simple term, evidence-based medicine can be defined as systematically reviewing, critically appraising the medical literature and using that to make a clinical decision to improve the care of our patient. That is the simplest definition of evidence-based medicine. Now, in order to optimize the care for our patient, we need to integrate the 3 components proposed by Dr. David Sackett. They are also called as a backbone of evidence-based medicine. So the first component is best research evidence. Now, what is best research evidence? There may be a different views. What do you consider best? We need to understand as a healthcare professional that not all research is equal, because the research is derived or a byproduct of different studies that are conducted. And the studies themselves, they are different. Some are observational, some are experimental. And the level and the quality of evidence that they produce is varies. So two studies cannot be treated similar or equal to each other. So the evidence generated by observational studies cannot be considered similar to evidence generated from randomized controlled trial. Now, the second component is clinical expertise and experience. And why is it important? It is important because there is a lot of variation in terms of clinical decision making. So just think about a patient who has a headache and he goes to the primary care physician. The primary care physician may prescribe him some painkillers and let him go. But if the same patient goes to some specialist like neurologist, that neurologist may do some 10, 15 different tests, even ask the patient to do CT scan. So you see there is a lot of variation in terms of clinical decision making. And this variation is just there because of the clinician's academic background, their level of expertise, and their years of experience, as well as their nature of practice. And lastly, we need to consider patient values and preferences because every patient is a unique individual and his needs may be different than any other patients. So the things which may not be important to the clinician from clinician's perspective may be important to the patient from his own perspective. For example, his religious beliefs, his access to care, his insurance status, his affordability of the treatment. So even though you can find a right solution to the medical situation by including base research evidence and clinical expertise and experience, at the end of the day, that decision may be changed or could be changed because of different patient factors. So what do we consider as an evidence? So there is a lot of confusion about what do we consider evidence. So in our day-to-day life, evidence is something as a proof in support of some claims or belief. But when it comes to healthcare or health intervention, it is the effectiveness of that intervention or the treatment to achieve the optimum benefits to our patient. And evidence is never meant to be just the anecdote or a personal intuition. So you cannot involve your personal feeling or your personal preferences in the treatment of patient. So in the era of information explosion or download, where are you going to look for the evidence? Okay. There are a variety of sources. Will you be interested in searching for the evidence in Google? Or are you going to rely on the social media, which is used nowadays, for everything? Or you're going to consult with your colleagues or expert in the field? Or you're going to rely upon the scientific journals, reputed scientific journals like JAMA or the New England Journal of Medicine? Or you will be more interested in looking at the treatment guidelines or the practice guidelines that are published by NIH or Indian Medical Association or Indian Pharmaceutical Association. So you see there is a diversity of resources that are available at our disposal, but they have different quality and different strength in terms of the research evidence. On the top of that, we have, tremendous growth of social media. And nowadays, social media like Twitter, Facebook, and Instagram is used by even practitioners or healthcare professionals. So just to give you one example, there is an Indian doctor, a young Indian doctor, who practices Western acupuncture. And majority of his clients are Bollywood celebrities, and he posts their picture on Instagram. He has a Twitter following of more than 157,000 people. And if you look at the Medline Plus, which is a best resource for finding medical information has only Twitter following of 100,000 people or 1 lakh people. Then you have a Baba, nowadays they are practicing medicine, and recently, I wouldn't say the name of this Baba, but you all know him. He recently launched a drug called Coronil for the cure of coronavirus. He has a Twitter following of almost like 2.2 million, whereas the Twitter account of Ministry of Health and Family Welfare of Government of India has only 1.8 million followers. So who are you going to trust? The people who are practicing on the social media, or the information which is provided by the reputable sources? What do you remember about the things that are listed on this slide? You know, all these drugs, they were recalled by the FDA for various reasons, and mostly for their harmful effect. So the Vioxx and Bextra, which were painkillers meant to treat rheumatoid arthritis, they were called off because of risk for heart disease or severe skin reactions. In terms of Bakal, which is a lipid-lowering drug, it was recalled by FDA because it was suspected of causing more than 100,000 people, suffering or dying because of rhabdomyolysis. That is one of the adverse effect of statins. Then you have 2 anti-diabetic drugs like Avandia and Resolin. They were also recalled because of their harmful effect on heart and liver. So why I'm telling you all these drugs? What is the purpose of it? Now these drugs, they were approved by FDA. Okay, they were approved by FDA after rigorous clinical trials. They were used by millions of patients all over the world. And after that, we realized that, oh, in fact, these drugs are harmful. So why EBM is important? So the reason I stated earlier, and the reason about the FDA recalls and the harmful effect of drugs on our patient, that is the reason we need evidence-based medicine, so we can make our decision based upon the best research evidence that is available to us. So on a daily basis, new drugs and research is introduced to us every day, is it? If you look at the FDA, in past, I guess about 20 years, they used to approve 20 to 25 new drugs every year. But that number is increased, almost doubled in last 5 years. Now they are approving almost 55 to 60 new drugs. When it comes to research, there are about 225,000 articles published worldwide every year. Okay, and there are about 70 articles per journal per year published in the United States. If you look at the traditional sources of information, such as textbooks, are not always good enough, because the textbook, you cannot use it maybe after 10 years, because the information is redundant in those textbooks. So we need a valid information to help our patient. So published information also nowadays could be misleading. The reason I already told you. So the knowledge and information is also becoming very redundant more frequently. So whatever you learn today, half of it, maybe about 50%, will be redundant in next 5 to 10 years. So evidence-based medicine help us to make a clinical decision based upon the base scientific evidence and combined with the clinical expertise and integrating the patient values and preferences. It allows us to share decision-making with patients. It provides better reasoning for diagnostic and therapy recommendations, so we can convince our patient that this is the best treatment for them. It helps us to understand benefit versus harm when we are making decision for certain drugs, especially chemotherapy or even anticoagulants. It also allows us to practice more safely and more effectively. Okay, so it's a quiz time. So let's brainstorm. You can again access this quiz by using the barcode or QR code or using the 6-digit passcode.
Sir, I think so quiz is not open.
It is not?
Open. It is giving the message that please wait for the presenter to activate it.
Okay. Just give me a minute. Is it on now? Are the attendees able to access it?
Yes, sir. I already uploaded that picture in a chat box.
Okay. Okay. So up to this point, we have talked about the concept of EBM, okay? The application or importance and relevance of EBM. Now let's talk about the nuts and bolts of EBM. So in order to practice EBM, there are 5 steps that you have to follow. So the first step is you ask a clinical question, a focused clinical question. In second step, you ask or you acquire, in fact, the evidence related to your focused clinical question. In step 3, you critically appraise that evidence which you obtained related to your focus clinical question. In step 4, you apply that evidence by integrating with patient value and preferences and also combining the clinical experience and expertise. And in step 5, you assess that process. The 4th step that you previously done, you assess whether you perform those steps properly or not. So let's talk about the first step. Ask a question. So asking a focused clinical question is a fundamental skill in evidence-based medicine. It helps us to structure our search so that we can find the best clinical evidence. Okay. So there are 2 types of questions. A type 1, they are called as background questions, and type 2, they are called as foreground question. Okay. So the background questions, they are very broad, and they generally ask about health condition in general. And they are consist of 2 parts. The first part is actual question, such as who, what, where, when, why, and how. Okay. Whereas the second part consists of something about disorder, test, or treatment, or intervention. Okay. So the background questions are necessary when our experience with the clinical question is very limited. And you can get the answer for background questions from resources such as textbooks or review articles. So if you think about our 2 patients, the background question could be, what causes myocardial infarction? Okay. What is the treatment for myocardial infarction? Why people get a myocardial infarction, or what are the risk factors of myocardial infarction? So those are the background questions. Okay. Then there are foreground questions, which are more specific to the individual patient or population, and they are very complex in nature. Now this foreground question, they consist of 4 components, which is referred by an acronym called PICO. And sometimes you may find that the T is added at the end of PICO. So let's expand on PICO. So in PICO, P stands for patient or population of interest. And not just the patient or population in general, but more specifically, the age of that patient, the gender of that patient, the race or ethnicity of that patient, or the past medical history of that patient. Now, somebody may ask why these demographic characteristics are important. The reason for that, the patient or the person who is 20-year-old with blood pressure and a person who is 80-year-old with blood pressure cannot be treated in the same way. Okay. Same thing goes with the gender. Okay. In terms of treatment of pain and in terms of treatment of nausea and vomiting, or even migraine headaches, you will see that the males and females, they are treated differently. Same thing goes for the race or ethnicity. Okay. Because of their genetic variation, some drug works better in Caucasian, white Caucasian, whereas some drug works better in Black African Americans. So we need to consider the patient factor while we are choosing our patient population, or we are exploring a clinical question in terms of that specific patient. The I in PICO stands for intervention or exposure. So exposure to a diagnostic test, or a prognostic factor, or a therapy, or a treatment. C stands for comparator. So what you are comparing against? Is it nothing, or is it against the placebo in case of randomized control trial, or is it comparing against another drug from the same therapeutic class or you are comparing against the gold standard treatment. Okay, so the gold standard treatment is nothing but a standard of practice. For example, if somebody is, having a stroke or have a risk for stroke, we put them on warfarin, which is a gold standard. Okay. For hypertensive patient, before we start any other treatment, we start them on diuretics first. That is a standard of practice. Okay, so that's a gold standard. Then the O in PICO stands for outcome, which is basically the end result of that intervention or the clinical effect of that intervention. And sometimes it is patient oriented, okay, such as pain or headaches, okay, or their quality of life. And sometimes you also see that the T is added and at the end of outcome, which simply refers to the type of question you are asking, whether it is a background question or whether it is a foreground question. So to put that PICO in terms of a focused clinical question, we can say that in patient population, we can define that patient, does intervention or exposure that we are interested in compared to the comparator, either placebo or a different drug, affects the outcome that you may be interested in. So that will be a focused clinical question. And this will help us to structure our search. So PICO is not just the acronym, it is a method for searching or for answering a focused clinical question. So what are the information resources for conducting such type of focused clinical search or focused search for the clinical question? We can use the primary resources such as original articles, published and unpublished studies or reports in journals, and then we can use the secondary resources like the PubMed or Web of Science, okay, or SINHAL or MBase. These are indexing and abstracting services. Or we can look at the systematic reviews or synopsis of individual studies. Then there are tertiary resources like textbook or full text databases. Or we can, if there is no information available, then we can seek that information, especially in phase 1 and phase 2 clinical trials from the pharmaceutical companies. Or we can consult with the consultants. So again, there are 4 types of foreground questions. They are called as therapy question, which normally looks at, the effect of treatments on patient, or finding out the difference in treatment effects or prevention of adverse events associated with those treatments. The diagnosis question normally looks at establishing a characteristics of the diagnostic test, whether they are accurate enough or not, by comparing with the gold standards that are available. In terms of prognosis question, we are basically estimating the future course of disease in the patient. And in terms of harm question, we are mostly interested in what are the harms of a treatment or intervention and how they can be avoided. So these are some of the examples of foreground question by using a PICO framework. So the therapy question could be, the example could be, in patient with migraine headaches, is valproic acid is more effective than topiramate for prophylaxis of headaches? Or in prognosis, does febrile seizures influence the development of seizure in kids compared to one with non-febrile seizures? So if you look at all these words that are highlighted in red, they tells you the patient or population, intervention or exposure, comparator, and the outcome that we are interested in. So searching for the evidence could be a very daunting task. Okay, so this is the 6S pyramid, which was developed by Hayes and colleagues, which can be used as a framework to structure our search when we are looking for the evidence. Okay. So majority of time the research is presented on a particular topic in the form of single studies. Okay, and there are thousands of single studies on particular topic that are published every day. Okay, and they are normally published in scientific journal like JAMA or New England Journal of Medicine, and they are abstracted either in PubMed or Embase or Web of Science. So these are the resources where you can look for the original studies, single studies. But think about it, like if you are looking for evidence for your patient and you have to go through thousands and thousands of studies. So it is a poor place to start your search. Okay, you can go one level up, which is called as synopsis of studies, which are nothing but a kind of summary of key finding of the single studies. And they are normally published or usually published in PubMed or in BMJ Clinical Evidence or in ACP journal clubs. Now, more and more individual studies are published on a particular topic. These multiple studies can be combined together to form a comprehensive document, which is called as systematic review. And if you statistically analyze these multiple studies, okay, to get the pooled estimate or overall treatment size of particular drug or intervention, that synthesis is called as meta-analysis. And systematic reviews and meta-analysis are normally available in Cochrane Library or on PubMed. Then on the top of synthesis, we have a synopsis of synthesis, which is again nothing but an abstract or a summary of key findings of the synthesis, which is systematic reviews and meta-analysis. And those can be found in BMJ Clinical Evidence or in ACP journal clubs. So if you don't have time to sift through all these studies and systematic reviews and meta-analysis, you can just go and look for evidence in synopsis of synthesis. On the top of that, you have summaries. Now, summary is one of the comprehensive source for finding the evidence because it's a combination of synopsis of synthesis and expert opinions. And they form a comprehensive document and they are published as practice guidelines or treatment guidelines by NIH, by JNC7 or by GOLD. These are different groups. Those are dealing with different types of disease condition. For example, JNC7 deals with the hypertension and cardiovascular diseases, whereas the GOLD deals with asthma and COPD. On the top of the 6S pyramid, we have systems. Now, systems are nothing but the electronic information systems, where the individual patient information is stored along with the practice guidelines. So it is easy access. You can see the patient information and the practice guideline at the same time. But these are mostly available in acute care setting. They are not available in primary care setting. So if you want to do a search for your clinically or your focus clinical question, you should start at the top and then go down to the bottom of the pyramid. So this is kind of a map where to start and where to go next if you're looking for the evidence. Then there is another pyramid which talks about the strength of the evidence that you obtained from these studies. So at the bottom, you have case reports and case series. These are very descriptive in nature. They just provide an unusual account of patients that are not seen in day-to-day practice. Okay, but these are individual reports. There is no comparison. On the top of case report and case series, you have cross-sectional studies. So within the observational studies, there are 3 different types of study design. One is cross-sectional study, then case control study, and then there is a cohort study. So cross-sectional studies are also called as snapshot studies because these are the snapshot where the exposure and outcome is measured at the same point in time. Okay. Whereas in case control study, the cases with the disease and the control without the disease, okay, they were followed to collect the information in their past, what they were exposed to. They are also called as retrospective studies because they are backward looking. They have an outcome. Now we are looking for the exposure, which may have been responsible for these people to have those outcomes. Then on the top of that, we have cohort study. The word cohort itself tells you it's a group of people with similar characteristics. Okay, so you have a group of people who are exposed and a group of people who are not exposed. Now these two groups, they are followed in the future to determine the target outcome. So those are prospective studies. These are forward-looking studies because we are following this patient in the future. Then we have randomized control trial, which is an experimental trial or experimental study design. Okay, where the patients are randomized and assigned to two different groups. One group gets the treatment or intervention, whereas the other group put on either placebo or some other drug comparator. Okay. And these patients, they are followed in the future for the target outcome. Now the randomized control trials are considered as gold standard. And the reason for that, because these trials, they have very low risk of bias as compared to observational studies such as cohort, case control, and cross-sectional. And they are conducted in very controlled environment. Okay, so randomized control trials are good for answering therapy questions, whereas the observational studies, they are good for answering harm questions or questions about the etiology or prognosis. Now, meta-analysis and systematic review, they do not fall in the category of study design itself because these are the synthesis of multiple studies. But they provide results which are kind of aggregate of multiple studies, and they have more statistical power compared to the randomized control trial. So why is it important to critically appraise the evidence? Because we need to understand the limitations of authors' analysis and the interpretation of data. We also need to assess the internal validity of that study. And here the internal validity is nothing but the accuracy and reproducibility. What if you conduct the same study 100 times? How many times you are going to get the similar results? We also need to assess the external validity, whether the results that obtained in this study or trial, how they are applicable to a larger population or to my patient. That's called external validity. And then we also need to identify potential confounding variables. Is there any third variable which actually influencing your outcome? So the good example that could be association between a coffee drinking and lung cancer. So if you find some association, we need to also find out if there's any third factor which is influencing this association, which could be smoking. Because majority of times the people who are coffee drinker, they also smoke. So the association that you found between the coffee drinking and lung cancer is not because of the coffee, but it is because of the smoking, which is a confounder or confounding variable in this trial. And then lastly, there is a Simpson paradox. So let me explain you the Simpson paradox by giving you one example. So you have a drug A and then you have a drug B, and you have two sets of population, male and female. So the drug A cures 70% of infection rate in male, and the number of male in this study is it is curing 70% of 90 people, it will be 63 people, they will be cured from infection. by the use of drug A, whereas the drug B is 80% effective. So you have 10 patients, so the 88 people from the out of that 10 will be cured for their infection. So here you can see drug A is not better than drug B. So drug B is better because the infection cure rate is 80%. Now, if you look at drug A in case of female, in female, it cures only 40% of infection rate. And you have 10 female in that group. So it will be 4 out of 10, 40%. In case of drug B, it cures 50% of infection rate. And you have 90 female in that group. So there will be 45 female will be infection free out of 90. So again, drug B is better in this case because it cures 45% of infection in female as compared to 40% of infection in case of drug A. So this is based upon the gender, considering the gender, okay, the effect of the drug. Now look at the overall effect of drug A, regardless of gender. We are not considering gender anymore. So it cures 63 people out of 90 among male, and then it cures 4 among female out of 10. So if you add 63 plus 4, it makes you 67%. You do the same thing for drug B, which is 8 plus 45, which makes that total to 53. So now here the drug A is much better than drug B. Whereas when we are looking at male and female independently, the drug B was better. So you see there is a conflicting results when you look at the different numbers. That is called as Simpson paradox. It is the inconsistency between the marginal interpretation and the conditional interpretation of the same data. That is called Simpson paradox. And this happens most of the time when the results are presented of research studies. And if you miss that, you will have wrong conclusions. Okay? So we need to pay attention to that. So why is that happening? Why is it happening? The simple reason for that, both groups do not have same numbers. Okay. For drug A, you have 90 male. Okay. For drug B, you have only 10 male. Whereas for female, you have 4 female for drug A, and then you have 90 female for drug B. So those numbers are not similar. And that is the reason you are getting those opposing results or opposite results based upon the condition, which is gender here, and the marginal relationship. These are the marginal totals. So if you are appraising a therapy study such as a randomized clinical trial, they have a key principle that you have to appraise them for. Okay? So you can appraise any randomized control trial from the beginning up to the end. So at the beginning, you can ask question whether in that randomized control trial, the patients were assigned to the treatment or control group were randomized. Was there any randomization in the assignment of this patient to different treatment groups? And was that randomization list concealed so that nobody knows what group they were assigned to? Where the groups were similar at the start of the trial, apart from the experimental therapy. So we need both groups to be exactly similar to each other, except the experimental therapy in one group. We can also assess the randomized control trial for during the trial itself, where the patient, clinicians, and study personnel, whether they were kept blinded to the treatment so that nobody knows what treatment they were getting. The patient didn't know what they were getting, whether it's a treatment or a placebo. Clinician didn't know, what drugs their patient were getting, whether it's a drug or the placebo, as well as the study personnel or the analysts who were involved in that randomized control trial also didn't know which group got what treatment. Was it placebo or was it intervention? So the next question you have to ask during the study also, apart from the experimental treatment, were the groups treated equally? So we have to provide equal treatment except the intervention or treatment to the one group. But both groups need to be treated equally. We can also appraise the randomized control trial at the end, where all patients who entered into the trial, were they accounted at the time of conclusion of that study, which is basically a loss to follow. So the biggest problem with randomized control trial, there are a lot of patients who just withdraw from the trial. Okay, that is called as loss to follow. They never show up, okay, at the middle of the trial sometimes, or even at the beginning of the trial, even though they are assigned to different treatment groups. And the most important question, whether all patients analyzed in the groups which they were randomized to. That is called as intention to treat principle, which is once randomized, the data need to be analyzed. Okay. So whatever patient they were randomized, regardless whether they lost to follow-up or not, we still have to use that number to analyze the data. So in order to understand those key principles, you can remember this FRISBE, the acronym, which stands for, F stands for follow-up of patients, R stands for the randomization and concealment, I stands for the intention to treat, S stands for the similar baseline characteristic, B for the blinding, and E for the equal treatment. So if you remember this acronym, you know what are the key principles that you have to look for when you are evaluating a randomized control trial. So when we are looking at the results of any research study, we need to have a basic understanding of statistics, because unless and until you have a foundational knowledge of statistics, you may not able to interpret or analyze those results. So there are certain common measures that we normally use in case of randomized control trial, and these are listed on this slide. So the first measure is experimental group event rate, which is nothing but the proportion of patients in the experimental group who had an event or who experienced some sort of risk with the treatment. Whereas the control group event rate represents the proportion of patients in control group who experience that event or risk without the treatment, because they are patients who either may be put on placebo. Then there is another important measure which is called as relative risk, which is nothing but a ratio of risk between the two groups, risk in the experimental group and risk in the control group. Okay, so if you take a ratio of that, it is called relative risk. Then we have odds ratio. So odds ratio is nothing but the ratio of odds in experimental group and odds in the control group. Now there is a difference in risk and odds. So when we calculate the risk, it is always the number of people or the proportion of people who had or who experienced that event over the total number of patients. Whereas when we are calculating the odds, it will be the number of patients who experienced that event versus or divided by the number of people who did not experience that event. So just to give you a simple example, if I say there is a 10% risk of stroke, okay, in patient, which simply means that 10 out of 100, okay, which is a risk. Whereas if I'm calculating the odds ratio, it will be 10 divided by 90, because 10 people have a risk of stroke, whereas the 90 people did not have the risk of stroke. That is called as odds. So when you take the ratio of those odds in experimental group and in control group, we can calculate the odds ratio. The absolute risk reduction is nothing but the absolute difference between the event rates in experimental group and the control group. So it is just the subtraction of the event rate from each other. And this is also called as risk difference. Then there is a relative risk reduction, which is a proportional reduction in the risk between experimental group and the control group. Okay. So how much proportion of the risk is reduced in comparison to control group? And the most important measure that we normally use with the randomized clinical trial is the number needed to treat, NNT, which simply means that how many people we need to treat to provide benefit to one patient. Okay, if that number is small, it means that the treatment has higher benefit. If that number is large, it means that that treatment is not that effective. Then there are two other measures that we normally use for harm questions, where we are looking at the harm caused by treatment or intervention. So one of the measure is absolute risk increase, which is exactly opposite to the absolute risk reduction. Now, in this case, the patient who were in experimental group had higher risk compared to the control group. So here we subtract risk in the control group from the experimental event group. Whereas in case of absolute risk reduction, we subtract risk in experimental group from the control group. That's the only difference. And as we calculate the number needed to treat, we can also calculate the number needed to harm. So number needed to harm is nothing but how many people you need to treat to harm one patient. So you need this number to be big enough so that we can say the harm is very low with this drug or this treatment. But if this number is very small, it means that that small number of people you treat, there will be one harm caused to the patient, or one patient will be harmed. So in order to calculate these measures, we normally use a 2x2 table, or which is also called as contingency table. So it has 2 rows and 2 columns. So the columns normally represents the outcomes, and the rows, they represents 2 different groups, experimental group and the control group. So if you construct this table, you will have 4 cells. Cell A, which is number of people in experimental group having an outcome. Cell B will represent a number of people in experimental group without the outcome. The cell C will represent number of people in control group having an outcome, whereas cell D will represent number of people in control group not having an outcome. Okay, so we can use these cells to calculate the different risk measure. So EER, which is the experimental group event rate, will be A over A plus B, A divided by A plus B, which is A plus B, total number. Okay. In order to calculate the events rate in control group, it will be C over CD. Now, as I said earlier, that odds ratio can be calculated by calculating or dividing the number of event versus number of no events. So in this case, the odds ratio can be calculated as A over B and then C over D. But if you know the foundational math, if you divide this, it will simply become A multiplied by D divided by B multiplied by C. So this is the easiest way to remember. This is a cross multiplication between these 2 numbers. Whereas the absolute risk reduction is nothing but the difference between these 2 event rate, experimental group and the control group. So CER minus EER, which will give you the absolute risk reduction. Whereas the relative risk reduction can be calculated by using subtraction of EER from CER divided by CER, because it is a proportional reduction in comparison to the control group. Or it can simply be calculated by 1 minus RR. So the RR you calculated here, you can just subtract that from 1 to get the relative risk reduction. And number needed to treat is nothing but a reciprocal of absolute risk reduction. So 1 over absolute risk reduction. For harm question, we can do the same thing. We can calculate the absolute risk increase by subtracting the control events rate in control group from events rate in experimental group. Whereas it will be reciprocal of ARI to get the number needed to harm. So these are simple calculations. These are not so complex. So if you do a couple of times, you will easily understand how simple these are and how easier to remember the method to calculate them. So this is the table that I created for our patient number 1, which we are talking about, because everything we are talking about in terms of those 2 patients. So I looked at a research and I found the meta-analysis. So I was, the second step, which is acquire the evidence. So I went through that 6S pyramid. And then I came across this meta-analysis, which is a synthesis, which is published by Weisman and colleagues. And I got these numbers from that study to find out, what is the benefit of aspirin to our patient 1. So in aspirin group, there were more than 3,000 patients. Out of those, there were 241 deaths because of all-cause mortality, which included myocardial infarction as well as heart failure. Whereas in the control group, there were again 3,000 patients, more than 3,000 patients, and there were about 291 deaths because of MI and heart failure. So let's calculate these numbers. So experimental event rate, which is 241 divided by total number, which is 0.076. You can convert that into a percent, which will be 7.6. You can do the same thing for control event rate in control group. So 291 minus, not minus, divided by 3,173. That will give you 9.1%. Okay. Now relative risk calculation, which is nothing but division of experimental event rate divided by control event rate. So 7.6 divided by 9.1, which will give you 0.84. You convert that into percent, it will be 84%. So it is less than 1. Okay. So which means that there is a risk reduction if you use aspirin compared to placebo. How much is that risk reduction? Is 16%. So if you take out 84 from 100, which is 1 minus RR, you will get 16%. Okay. So there is a risk reduction if you put somebody on aspirin. Okay. And that risk reduction is at the extent of 16%. We can use that number, this ARR number. So now, if you look at the relative risk as well as relative risk reduction, this number looks impressive. 84%, 16%. But just take a look at now the absolute risk reduction, which is subtraction of events rate in experimental group from control group, and you get 1.5. So the absolute risk reduction is only 1.5%, whereas the relative risk reduction is about 16%. Okay? I'm going to talk about it, which measure you should focus on when you are making a clinical decision. Okay? And if you calculate the number needed to treat, it will be about 67, which means that if you treat 67 patients with aspirin, okay, compared to placebo, one death can be prevented, which is good. So here I put this table on this slide to show you how to make a clinical decision based upon these numbers. So I have three hypothetical randomized clinical trials. Okay. In one trial, you have low risk patient. In the another trial, you have moderate risk patient. And in trial C, you have high risk patient. There are 40 patients in this trial. There is about 200 patients in this trial, equally divided between two groups. And then there are 2,000 patients in this trial, which has high risk group people, equally divided into control and experimental group. So when you calculated the event rates in control and event rates in experimental group, you had 2% risk in control group, okay, of stroke if they are using thrombolytics. Whereas they had 20% risk of stroke if they are in moderate risk group. And they had 50% risk if they were in high risk group. In terms of using thrombolytics, the risk was reduced by 1%. Okay. So if you look at the absolute risk reduction, it is 2 minus 1, you get 1% reduction. So the event rate in experimental group was 1%. So 1% rate reduction, absolute risk reduction. If you look at the control group here, the absolute risk reduction was 10. So 20 minus 10, you get 10. If you look at the high risk group, there is a 25% risk reduction with the use of aspirin. But if you look at these numbers, they are constant, regardless of the risk of these patients. So if you have to decide whether to use thrombolytics or not, what type of patient you will choose and what type of patient will benefit more from using thrombolytics. Definitely the patient with high risk, because there is a 25% risk reduction. Okay, whereas in low risk patient, it's only 1% risk reduction compared to the placebo. Okay, so that is how your treatment decision changes clinically when you look at the patient with different risk, which simply tells you that you cannot use drug, okay, same drug, same doses, okay, or same duration of treatment for all of the patient. You have to consider their risk in order to make that clinical decision. So if I have to decide to choose thrombolytics for the treatment of stroke, I will prefer that to be used in high-risk patient compared to a low-risk patient. Again, if you look at the 95% confidence interval of relative risk reduction, you will see that it ranges from minus to plus, which means that these results are not statistically significant because it includes a point of no difference, which is, this is a risk ratio, so it will be 1. So this range will include 1 in between, and that is the reason this result is not statistically significant. So this is a graphical representation of the same result, but by putting this numbers in graph, it will be easier to interpret those numbers. Okay, so that is the reason we normally use graphs to display your results. This is the graph, or you can say a figure, which is called as, or a plot, which is called as forest plot, which you usually see when the result of meta-analysis are presented. Now, there's a line in the center which represents a point of no difference, which is 1. If the risk ratio or relative risk is 1, which means that the risk in both groups is exactly same. There is no difference. Okay, but if the relative risk falls to the left of this line, which means that the treatment is good. But if it falls on the right-hand side of this line, then it means that the treatment is bad and the relative risk actually favors the control. Okay? And if you combine these results and present them as an aggregate, you will see that in this case, it is falling exactly at the center of this line, which means that even if you take collectively the result of all these multiple trials, A, B, C, D, you still don't see any treatment benefits. So in this case, if you're comparing a treatment with the placebo, your conclusion will be the treatment is not effective. It is as good as a placebo. These lines, okay, on the left and the right, they represents 95% confidence interval. And you can see that these lines, they are passing through this center line, which simply telling you that the results are not statistically significant. So let's move on to the step 4, which is applying the evidence. How you are going to apply this evidence for your patient. So before doing that, you have to ask the question, are these results are applicable to my patient? Okay. And if the answer is yes, then you are going to look for some other characteristic or other explanation. For example, are the study participants have similar demographic characteristic, severity or comorbidities that I have in my patient? So can I apply these results to my patient? Is my patient is similar to the patient they were participating in that clinical trial? Are treatment options feasible in our setting? So sometime, with some therapy, there is cost involved, there is education involved, there are a lot of resources involved in order to provide that treatment. So we have to look at the infrastructure, resources, time in order to provide that treatment. So feasibility of that treatment, you have to look for, whether it's feasible for you to provide that treatment. Are results applicable to my patient in terms of outcomes? Am I looking at the same outcome as the study looked at? Or the study looked at something else and I'm interested in something else in terms of outcome. So we have to make sure that we are looking at similar outcomes, not apple versus oranges. The next question is, what are the potential benefit and harms to the patient with or without therapy? So what if you decided not to offer this therapy? Okay, what will be the harm to the patient? Or, that you need to think about. Or what could be the alternative treatment if we don't use or don't provide this option to our patient? And then lastly, what are our patient values and expectation for the treatment and outcome of the treatment? Because we need to know that what the patient is looking for. Okay, from clinical perspective, you may feel that, oh, this treatment is going to provide maximum benefit to my patient. But the patient may not be willing to pay the cost of that care. So at the end of the day, you still have to ask what is good for that patient and what that patient is interested in terms of his treatment. So the most important question is, does my patient want this? Step 5, we have to assess the process that we use to come to this conclusion. Okay, so we have to start with examining the approach that we use to do this, synthesis of evidence and then applying that evidence to our patient care. We also need to check for the appropriateness of the quantity and the quality of evidence that we gathered. So in our patient cases, I looked at the 2 meta-analysis. So when you look at the quality of evidence, they are above the randomized control trial. So they have a good quality of evidence. In terms of acquiring the evidence, it was easy. I just looked at the PubMed and I was able to find those studies. So I didn't spend any money to get those manuscript or those articles in order to access them. Okay. And the last step is to evaluate the response and the degree of compliance on the part of patient. Because at the end of the day, even if you suggest that treatment to your patient, you need to find out how compliant that patient will be to this treatment. Okay, so it's a shared decision. You have to talk to your patient and find out like what they are expecting from this treatment. And the last most important aspect of evidence-based medicine is to present and communicate the risk and benefits, because it is the hardest part to talk to your patient and tell them about the benefits and harm of the treatment or intervention. And sometimes the kind of word you use influences the patient decision. So you have to rephrase your question. You don't want to get, you don't want to give a negative impression to the patient. So you always have to talk positively. When you explain the numbers to your patient, some are good in understanding the numbers, some may not be. So you have to explain that in very simple and layman terms when you're talking about the numbers. It is not good to talk about negative outcomes. So if you are saying something like, oh, in your condition, there is only 1% chance of death associated with this treatment. Are you willing to take this risk? This death itself indicates that, oh, it's a negative outcome. They are not looking at that 1%, which is bare minimum. But if you rephrase that question, or if you rephrase that wording and you say, oh, there is a 99% of chance of survival for someone in your condition, and this procedure is relatively safe, the patient may be more willing to take that advice. So you have to always frame your reasoning and your counseling in a positive sense, because the patients are more willing to go with the positive outcomes compared to the negative outcomes. Because human beings are, we don't want to take risk. We want certainty in everything. We don't like uncertainty. Okay. And, sometimes the patient cannot make that decision themselves about the risk and benefits. So you have to explain them in a layman term, make them involved, make them understand what you are telling them, especially for the drugs such as chemotherapy, drugs that are used for strokes or heart failure. You need to explain these drugs to your patients and the risk and benefits associated with those treatments. Okay, so this is the last quiz. Okay, so let's get back to our patient where we started. So here we are using those 5 steps. So the focus clinical question for our patient will be, in patient with MI, which is our first patient, history of clot, which is second patient, does prophylactic use of aspirin, which is intervention, compared to no treatment, which is placebo, or not taking any treatment, reduces the risk of CVD events in future, which is the outcome. I already told you that I acquire this evidence in the second step using the synthesis, which is meta-analysis. I appraise the evidence, the table I already show you for our patient 1, where we calculated the number, which is 67, okay, number needed to treat to prevent 1 death, okay, for our patient 1, whereas number needed to treat of 100 to detect 1 non-fatal GI bleeding. So it is relatively safe. Whereas for the second patient, the number needed to treat for aspirin to prevent 1 major cardiovascular event was 3 only for every 1,000 patients. So if you treat 1,000 patients, only 1 will get benefit, or 3 will get benefit in this case. Over a 5-year period, like you have to wait for 5 years to find that outcome. Whereas it will cause 3 major bleed per 1,000 patients treated. So there are bleeding chances also. And no benefits were observed with aspirin in primary prevention. Now our patient has no history of cardiovascular disease. Okay. So how do we apply this evidence? So for patient 1 who has a 10-year risk of cardiovascular mortality, about 10%, aspirin is recommended as a secondary prevention of future CVD. Whereas in our second patient, it is not recommended because our patient do not have any underlying cardiovascular disease. He already had 1 surgery for removal of clot. With the aspirin, there are always chances of hemorrhage and bleeding. So it will not be safe. And if you look at the number needed to treat, this may not be useful. And his 10-year risk of cardiovascular mortality is only 4%. Whereas the aspirin is recommended for patients with like 6 to 10% risk. So our patient, this patient doesn't fall into that category. So we cannot recommend aspirin for our patient B or patient 2. In terms of assessing the ABCP process, there was no difficulty in acquiring the evidence. There was no cost involved. And the evidence was of good quality because they were meta-analysis. So to conclude my presentation, evidence-based clinical practice, it emphasizes the use of base research evidence from the medical literature as a guide. It minimizes the impact of personal intuition, personal clinical observation, and expert authority. And it integrates the patient values and preferences to make informed decisions. So before I close my presentation, I would like to take this opportunity and highlight some of my research students who work with me over the years. Some of them from my own school, College of Pharmacy, and some of them were external students who work with me during the summertime. And these students, they have presented their research in international conferences. They have published in journals, and I'm really proud of them for their help in conducting my research. If you would like to know more about my college, you can go to this website and access our webpage. These are the resources for my today's presentation. So thank you all for listening, and I'm happy to take your question at this time.
Thank you, sir, for this wonderful session. You have given the eye-opening statements regarding with the precision in medication. Currently in underdevelopment countries, mostly this base is not much considerable during the clinical practices, but in developed countries right now, this is more emphasizing about the treatment of the patient by taking a consideration of this particular personalized medication and precision in medication, so that the complication in the upcoming generations or the past, by taking the past history to avoid the such kind of the adverse effect and interaction, this is much more useful. Now this is the session for the question answer. So those participants who want to interact with our eminent speaker can raise your hand. There is a one option is given on your Zoom meeting screen, that is to raise your hand, so I can unmute him or her to interact with our eminent speaker. Sir, can we proceed, sir?
Yeah, sure.
As there is the first interactive is Vedika Sarodey. I am going to unmute her mic so she will able to ask the question. Yeah, Vedika,
Hello.
continue.
Yes, sir.
Yeah, you are audible.
Hello, sir. My question is for doing career in evidence-based medicines, what is the criteria for it?
So if you would like to do something in evidence-based medicine, especially in the United States, the basic requirement that you need to have a bachelor's degree if you are educated in US in health sciences. It could be any field, but that need to be related to health sciences only, because you need some kind of exposure to the health science. There are residencies, then there are 2 years fellowship in evidence-based medicine, because this field is growing tremendously in developed countries. There are actually centers, even in US, there are about 10 to 12 centers. Their job is only to do evidence-based medicine, analyze the data, analyze the research studies that are published every day. So Cochrane Collaboration is a host. It is one of the best institutions which look at the evidence-based medicine. Okay. So there are fellowships, there are residency. Now the residencies are mostly for PHARM.D students who have a basic PHARM.D. So they can go on doing residency or go on doing fellowship. If you are coming from outside, such as any other country into the United States, then I will advise you to have at least a master's degree in health sciences, and do some kind of seminars or workshop or certification before you apply to these programs.
Yes, thank you, sir. Second question is coming from Sakshi Ikhar. Sakshi, you can ask the question.
Yes, sir. Am I audible?
Yeah, you are audible.
Good morning, sir.
Good morning.
Sir, my question is that if evidence-based medicine is possible in illiterate patients?
Yeah, it is, because we are practicing here. A lot of people have misconception about the United States. It is like any other country. You have poor people, you have rich people, you have illiterate people, you have highly educated people, like in India. So we have people who cannot read above the 6th grade level. Okay. And those are the people who are coming from other countries, like Latin American countries, or coming from Caribbean, or coming from Middle East. Their primary language is not English. so they cannot do conversation with you. They don't have education, you know. So yeah, we do have illiterate people, and they still use evidence-based medicine to improve their improve their care. Evidence-based medicine has nothing to do with the, the literacy of that patient. Our goal is to improve the care of that patient.
Yes, sir, right.
Next interactive personality is Dr. Jagdish Manwar sir. I'm going to unmute his mic so he can ask the question. Yeah,
Good morning, sir.
audible now.
Hello, good morning, sir.
Good morning. Yeah.
Sir, I want to know, can our medicinal chemistry correlate with this topic? Actually, I want to publish a paper regarding this.
So if you want to publish a paper on this topic, definitely you have to get some background information, learn a little bit more about it. There are a lot of resources that are available on internet. You can go to the McMaster University website. There are free courses, there are free videos which you can watch, which will make you understand better what is evidence-based medicine. So that will be helpful for you to write a paper on it.
I think it's somewhat new in India, sir.
Everything is new in life, is it?
Yes,
everything
sir.
in life is new. At some point in time, we have to learn. When we are baby, we learn to walk. As a baby, it is a new thing for us. Knowledge can be acquired. Okay, nobody, born with knowledge. You acquire knowledge.
Yeah. Absolutely right, sir. Okay, thank you, sir.
Sure.
Thank you, sir. One question is from my side also, sir. I want to know that evidence-based synthesis is how much useful when we are discussing about the orphan diseases.
The problem with orphan diseases is that there is not much literature available, because there are no incentive for pharmaceutical industry to manufacture orphan drugs because of the prevalence of that condition in the population. So the research is not there as much as it is there for the chronic diseases. Okay, because there are more and more patients using drugs for chronic diseases. But it doesn't matter, what disease condition you are looking at. Whatever evidence you have available at this present time, we have to make best use of that evidence. It doesn't matter whether it's an orphan condition or whether it's a chronic condition, which is more prevalent in the population.
Yes, sir. I'm asked that question just because of we recently got one more virus in a South African continental, that is the Ebola virus, and we are not getting a much evidences for treating that particular infection.
Yeah, see, the problem with even coronavirus now, even if the pharmaceutical company is interested to manufacture vaccine for coronavirus, what is the guarantee governments are giving to these pharmaceutical companies that whatever amount of money they are putting into research and innovation to get this vaccine will be recovered? Because as soon as the vaccine become available, it will be immoral to say that we cannot sell this vaccine at cheaper prices. So who is going to guarantee that?
Yeah, that's definitely right, sir. Uh, More participant from us, that is Mr. Rajendra Adesar. I'm going to unmute his mic so he can talk with you.
Sure.
Professor Rajendra Adesar. I think so. He might lose his connection. I will take further question if anybody is there asking.
Mhm.
Sagar, sir.
Yeah.
Sir, one question from my side.
Yeah.
Uh, Good evening, sir. Prashant, sir.
Yeah, good evening.
Sir, is it possible that everyone is talking that the vaccine will come by the end of September or October, and we know that all the means when we develop any drug or any vaccine, the safety profile is on the priority. So, is it possible that the trials will be done and the safety profile will be evaluated and then vaccine will be launched by the end of the September or October for
No,
COVID-19?
no one can guarantee that. The reason is very simple. Everything is about money, is it? The companies, pharmaceutical companies, are there for their profits. Unless and until you see there is a need or they can make money out of it, they're not going to rush for it. That is what happens with the orphan drugs, is it? Because the prevalence of that condition is so low in the population. How many patients are going to use, even if you develop some drug for orphan diseases?
Yeah,
And who is going to, guarantee them the return on their investment?
yeah. So no one is means uh,
No,
getting.
it can happen. I will definitely tell you there will be a vaccine, but most likely that vaccine will be developed in underdeveloped countries, not in developed countries.
Okay, thank you, sir.
Sure.
Uh, there is no more question is getting right now from chat box, and no one is raising their hand right now. But if any question get from a participant during the feedback and certain cases, we will definitely carry forward you, sir. So they will get better understanding about the topic and the related information what they want to ask. Maybe this is the mostly a new things for every participants, because in India right now such kind of the practices is not in a currently right now, not now here. They are getting the information for the collecting the information for designing the proper synthetic data to implement it properly for the each and every patients. So here I conclude the question answer session. Now I would like to invite Professor Motule Madam for conducting the valedictory session. Over to you, ma'am. Yeah, you are audible and your video is visible.
Good morning all, and good evening to our respected speaker. I, Professor Anuja Motule, on the behalf of Dr. Rajendra Gode, Institute of Pharmacy, Amravati, feel very honored and privileged to get this opportunity to express a deep gratitude to our honorable speaker, respected Dr. Prashant Sakharkar sir, for sharing such an enlightening presentation on evidence synthesis and its application in patient care. Your words of wisdom sheds light on such a complicated area with ease and delicacy. We are extremely thankful to sir. This session, it was really eye-opening, and today we had an opportunity to hear your informative words, and this will definitely help us. And the idea of quiz was fantastic and made it super interactive. Thank you so much, sir. Now I extended my thanks to our beloved Honorable President, sir, Mr. Yogendraji Gode, for encouraging and inspiring us for organizing such kind of events. I also thankful to Dr. R.L. Bakal, sir, Principal of Dr. Rajendra Gode Institute of Pharmacy, and Professor H.S. Sawarkar, sir, Principal of Dr. Rajendra Gode College of Pharmacy, for unstated support and minute-to-minute guidance to us. I would like to express my thanks to our organizing committee, Professor P.V. Ajmire, sir, Professor S.N. ANDE, sir, and Professor C.A. GULHANE, sir, who initiated to organize this webinar series and took all efforts to make this webinar successful. And also thanks to all our faculty members for enormous cooperation and support. My thanks goes to all honorable delegates, all assembled faculty members, and last, all participants for showing their interest and interactive response for the global webinar. I hope this session filled your knowledge cloud with valuable information. Thank you all for making today's session a huge success. Thank you all. Further session over to you, sir.
Okay, thank you, ma'am, for giving valedictory session. I would like to express my gratitude towards our today's eminent speaker, Dr. Prashant Sakharkar, sir, who spent his valuable time for giving the knowledge regarding with the new era of evidence synthesis and patient care. Right now, India is marching with the culting the students who get the knowledge from their course, that is the PHARM.D course, Doctor of Pharmacy. I would like to share one thing over here with the participants that in India, we are getting the degree of PHARM.D after the 6 years, but there is a one provision at the Roosevelt University where the sir is currently now the faculty over there and head of the department. There is only 3 years required to complete their PHARM.D course. Sir, if you can say something about the course so the participants or the students may also get more information regarding with this course.
Sure. So our program, our PHARM.D program is called as Accelerated PHARM.D program. So the traditional PHARM.D programs are 2 years of pre-professional course and 4 years of professional course. So somebody who is coming with the bachelor's degree can get into professional course. So he has to complete only 4 years. But if you do not have a bachelor's degree or an associate degree, then you have to go through the 6-year program. Okay. Ours is a 3-year program. So what we did basically, the traditional 4-year program, they runs on semesters. So there are 3 semesters in a year. So there are total 12 semesters in 4-year program. Whereas we have quarters rather than semester. So we run 4 quarters in 1 year to make that 12 in 3 years. So there are no summer breaks. Once the college starts, it just continues without any break. Whereas in the traditional program, you do a fall semester, then you do a winter, which is combined with spring, and then you get a whole summer semester off. There are no classes. Nothing goes on there. So we are saving that time for the students. And students don't mind it because they can get out 1 year before into the market, job market. So that is the only difference. It is not that our program is different than the 4-year program. It is just that we don't have any breaks. There are no breaks.
Okay, thank you, sir. Thank you very much for giving your valuable time for this session and continuously remaining with us and guide us to conduct this whole international webinar series. Without your guidance, it is not possible for me and my institution to conduct this webinar. Thank you very much, sir. We will stay connected with you and hope so you will guide us in future also. Thank you to all the participants. Here I declare that the session is going to be concluded right now. There is a feedback form get available in a WhatsApp group, in a chat box, in a YouTube channel. So you have to fill it. So we will carry forward that feedback form to our eminent speaker. So if any queries may get remaining to get asked over here during the session, you will also get reply on your feedback. Okay, thank you. Thank you very much to all participants and my organizing committee members for putting their efforts to conduct this session. We will see you on the tomorrow to conduct the next session, that is the day 3 of the international webinar series, Facet of Pharmacy. Thank you, sir.
You're most welcome. Thank you.
Yeah. Good night and stay safe.
You guys too.
Thank you, sir.
कसं झालं सागर?
Yes, sir.
कसं झालं म्हटलं?
सर व्यवस्थित झालं एकदम.
अच्छा. जास्त वेळ तर नाही घेतला ना मी?
नाही सर, आपला टाइम पिरियड जो होता त्या हिशोबाने बरोबर 9 वाजता चालू झालेला आहे आणि 11 वाजता संपलेला आहे.
अच्छा.
एकदम व्यवस्थित. चालेल सर, मी मीटिंग एंड करतोय. मी वरती कॉल करून मग बोलतो थोड्या वेळाने.
Okay. See you then. Okay. I'll talk to you then. Yeah.